a debatable issue in the management of myopic traction maculopathy. This buckle is a modified form of the endoplumb. It has been developed in collaboration with the labs of the Japanese University in Alexandria. So the buckle contains a titanium wire which makes it rigid enough to indent the sclera. It could be bent at surgery to give the adequate curvature suitable for the staphyloma. And it has an indenting tip in the terminal part, which is meant to be put under the macular area. There is an opening anteriorly through which a tissue adhesive is applied to fix this buckle to the surface of the sclera. A microdiode is incorporated in the back surface of the buckle, and with an inductive coil, this illuminates wirelessly to know exactly where your buckle is at the time of surgery. So we expose the upper temporal quadrant. We identify the temporal long posterior ciliary vessels, which pass exactly from the insertion of the inferior oblique and go directly to the macular area. Insert the buckle, put the tissue adhesive to fix it in place. This is the indenting tab right there. Should be put here at the macular area to change the concave configuration of the sclera into a flat or slightly convex configuration. Let me present the first case with high myopia posterior staphyloma macular detachment. This is on presentation. A decision to put a macular buckle and gas has been taken after identifying the place of the macular buckle. Let us see what happens after surgery. This is the first postoperative day. Notice that the volume of the fluid at the macular area has decreased a lot in the first day. The hole was still open. So this was on presentation 1 week after surgery. The colloidal vascular pattern is much more evident. And this is the OCT 1 week after surgery. Indentation effect of the buckle is seen, and you can notice between the edges of the hole, which is still open, a fibrin plug is forming. 2 weeks after surgery, the horizontal scan of the OCT demonstrated closure, almost closure of the macular hole with subretinal fluid present inferiorly. Notice the difference between the first week and the second week in the OCT. And then on follow-up of the patients, notice every time we do the OCT, the fluid decreases. 3 weeks after surgery, this was the case. 4 weeks after surgery, the fluid decreases more and more. If you compare this vertical scan of the inferior fluid inferiorly, it decreases all the time. So after probably 9 weeks, the retina was totally attached, hole closed, very little amount of subretinal fluid is there. The second case of myopic macular hole retinal detachment, which is extending inferiorly. Notes after macular buckle, first postoperative day after the macular buckle. Compare the colored photograph with the photograph before surgery. The colloidal vascular pattern is much more evident, and 10 days after the surgery, the hole was closed and the retina was totally attached. And this actually has been maintained afterwards. The third case of a myopic macular hole retinal detachment, notice the other eye. The other eye of the patient has been operated for vitrectomy and silicone oil. The eye was silicone oil filled, detached, dating 3 years, visual acuity with hand motion. So a decision not to do a vitrectomy in the right eye, we decided to do macular buckle and gas. Notice this is 3 days after surgery. The retina was attached, but the hole was still open. And then 1 week after surgery, the retina was flat and the hole was open. At this point, you have to think what to do more. Does vision of this patient will improve after doing a surgery for the hole to close it, like eyelid peeling with a flap or not? In fact, the central area shows an atrophic retinal pigment epithelium, which I believe will not lead to visual improvement after surgery. So I have been satisfied with this result and have done nothing more. On the contrast, this patient has a healthy retinal pigment epithelium and full thickness macular hole. After surgery, the retina has been attached and the hole has closed. This patient deserves another surgery to remove the ILM and close this macular hole after retinal reattachment, which is definitely easier than the previous case. This is a case of predominantly outer schisis with lamellar macular hole. We have put a macular buckle. Notice 1 day after surgery, the indentation effect of the buckle was there. The condition continues to improve, and finally, at 6 months, the retina was totally attached with a macular buccal gas. You know the difficulties in the removal of the ILM in those very high myopic eyes with posterior staphyloma and atrophic retinal pigment epithelium. This is another case of myopic traction maculopathy with evident traction at the macular area. And on presentation, this was the case like this. And this is 2 weeks after surgery, the volume of the fluid decreases, and 3 weeks afterwards, the retina was attached despite the presence of this vitreous traction. And this is about 2 months after surgery. Compare it with the preoperative photograph, you will notice that the fluid has completely gone away. Another case. If it is okay like this.
Thank you,
okay.
Dr. Ahmed. You are an expert in buccal, so I would ask Dr. Mohammed Moghazi, do you have an experience with the buccal? And let me ask you why many vitreoretinal surgeons are hesitant to use the buccal in such kinds of surgery.
Hey, first I would like to congratulate and thank Dr. Ahmed Bedda for sharing his experience in the buccal. Most of us don't have the experience, and this actually answers your question. It's not that we're reluctant to try the buccal, but it's not available. And so many models came and went, and it was not commercially available to buy. That's why probably most of us didn't try it enough to make a proper decision of the merits of using the buccal. But from the cases that Dr. Magdy Bedda and I also cases from Barbara Parolini, I think buccal is still a very good option in those cases. I have one question for you, Dr. Magdy. Did you develop a nomogram specific for this type of buccal according to the axial length of the eye?
No, this is what's different with this buccal than the other buckles like the AGL buckles Barbara Parolini uses. In fact, after doing a lot of trials to determine exactly where the buccal is, I found that it's much easier than before. We don't use these days the light you have seen. Just make a line between the superior rectus and the lateral rectus and move posteriorly. When you move posteriorly until the end, you will reach the optic nerve. So put the buccal in this line, and once it doesn't move, you are touching the nerve. So move it anteriorly, about 4 millimeters, you will be always in the proper position. This is a final conclusion to make it easy.
Thank you, Dr. Ahmed. Dr. Tariq, there is a debate going on that's is it to remove the ILM, which is the cause of the schisis, or to tackle the things from this clear side like a bucket?
I am very impressed by the results of the macular buccal. I wish we had it available in the US because I have few cases that I think they have the perfect indication for the macular buccal. I mean, we've tried ILM peel on these patients and sometimes autologous retinal transplant to close the macular holes. But in some cases, I feel like the macular buccal is exactly what you need in order to fight that posterior curvature that is a bulging of the eye. Excellent. I wanted to ask you, do you just put the adhesive tape and you don't need to suture the macular buccal in regards to the technique?
You are asking about how to fix the macular buccal?
Suturing. Do you need to suture or
not? No, not at all. We invented the hole in the anterior part of the buccal so that you put the adhesive, just keep the anterior end of the buccal in place for 2 seconds. It will work and fix it in place. The problem in these cases, if you would like to take suture, you take it posterior at the equator. The sclera is very thin, the chances of perforating, and it takes a long time. Just put the 2 seconds, it will fix it. And this procedure doesn't take more than 20 minutes to finish the surgery like this.
Yeah, I think this will make more surgeons courageous to do such kind of work.
Exactly.
Thank you, Dr. Bedda, for your very nice presentation. May I call upon our next speaker, Dr. Yahya Al-Zahrani. Combined hamartoma of the retina, RPE, operate or not?
Assalamu alaikum. Good morning, everyone.